Hi, welcome to another edition of Your Health Matters with Dr. Benjamin Bryant, Chief of Staff and Chief General Surgeon at UH Conneaut Medical Center. Doc, how you liking this weather?
Gosh, well, you know, what if all the flowers start blooming and then we get a big freeze?
I'm afraid of that. I'm afraid, some of them have.
Yeah.
They're coming up out of the ground.
I was in Ann Arbor last weekend and the daffodils are coming.
Yeah.
In February.
It's not right.
It's good. Meanwhile, we enjoy the...
I'll take it.
Yeah.
I'll take it.
That's right.
I see you have a good friend of ours here today.
Oh, gosh. Well, I was just telling Dr. Abby how grateful we were that she took time from her schedule to come and be with us today. Dr. Abby is an internal medicine doctor with UH here at UH Conneaut. I'm pretty sure that most of the public knows her pretty well by now. Dr. Abby is what's called the Chief Medical Officer of UH Conneaut Medical Center. It's a very important position, a position with a lot of responsibility. Dr. Abby, thank you so much for coming in.
My pleasure. Happy to be here.
What is a Chief Medical Officer?
So a Chief Medical Officer has certain qualities and roles that are associated with that position. Most hospitals all have at least one of them. We are predominantly responsible for managing patient satisfaction for one, and quality metrics for another. Those are our big things. Quality to me trumps everything else. So making sure that we are watching mortality rates, making sure that they're reduced, and if we ever have a mortality, which is a patient death or anything like that, we're going into why that happened, what can we change in terms of our policies and procedures to prevent that from happening again, readmissions, falls, all those things that tell us how good truly a hospital is and how much they're focused on patient safety, which is our primary goal. A chief medical officer really manages all of that and makes sure that policies and procedures are in place to minimize anything that can happen to a patient negatively in the hospital. Patient satisfaction is also very important. So when you come to the hospital, how well were you treated? How happy were you with those services? We have monthly quality meetings where we go through our patient satisfaction scores and make sure that they're good and that we're doing the right thing for the patient. Being part of university hospitals as a system, we were 1 in 3 hospitals within the UH system to win the award for 100% patient satisfaction. So that was an incredible achievement for us last year, and the award was presented at a system meeting, which says a lot about UH Conneaut.
It does. We attend these meetings and we see how UH Conneaut stacks up within the UH system.
Right.
And we're always at the top out here.
We are.
We are always at the. We've even had other UH hospitals come out and try and find out how we do it.
Absolutely, absolutely. And I had one ask me actually yesterday if they could bring their team to watch our our morning rounds with our team and to follow us. And that's an incredible achievement.
Oh, it really is. It really, really is.
Is it hard, Dr. Abby, to juggle your regular practice with that position?
I can't speak for everyone, but I would say I have an abundance of energy, so I
know you do.
I prefer to have it that way. Most of the administrative work can be done in between my patients, and I don't really take a lunch, so I like to do a lot of it during lunchtime. And then a lot of the other things where you integrate our hospital with the rest of the system, so going out to dinners and meetings to find out what's happening at a system level happens at night. And then any kind of report development that I have to do, policies that we're going to change or anything, I do that during the weekend. So pretty much my job is my life.
Dr. Abby and I, as you know, you introduced her on our show.
Sure, I do remember that.
It's about over 3 years ago now. We got to know her very well from many appearances that she made then. And I was always impressed with your energy. And I always wondered how you kept up, but you told me you keep yourself in good physical shape.
Yes, and I do have to say, and this is an idea that's been coming to me a little bit to work with staff here as well, the more you do outside of work physically, the more energy you have for work. And when you have those workouts or exercise regimens in the morning, you really gain that energy level so that you can be very, very productive and efficient. It's all about efficiency. It's not about how long you're doing something, but how efficient you are when you're doing it.
Yeah.
So,
excellent. Now your hours are what are your days and hours?
So my hours are still the same as when they started. Mondays are late day. We start a little bit later and we go a little bit later in the
Okay.
evening to accommodate any of the patients that work and need to come to see the doctor later. Tuesday, Wednesday, and Thursday we're 9 to 5. And Fridays we're 9 to noon. So in the afternoon I get a little bit more administrative time.
I know when you first started, being new,
Mhm.
it was hard to get people to know you and stuff.
Yes.
So hopefully that show helped out a little bit. And of course, the advertising that UH did to get your name out there. And I understand you have a very good clientele now.
Absolutely, yes. We are up to usually around 20 patients a day. I do have a partner to help me out now. We have Dr.
Dr.
Yes,
Kumar, he's
yes.
been on the show.
Yes, he has.
Yeah, so we're totally able to take that, that volume.
Sure.
And we definitely want someone to always be available for the patients in the community, so that's our goal.
Excellent.
Yeah, it's very important. I mean, I encounter patients who their care is what we would call fragmented, okay? They go to doctors in different systems and so on and so forth, and people are becoming more sophisticated now. They understand, they're starting to understand the benefits to them to have all of their medical information in one record, because that really makes things, in terms of efficiency, like Dr. Abby was talking about. If all of their information is in one record, then things aren't going to be missed. You go to see the doctor, they have your entire record, they can pop it right up, see all the tests that have been done, see what other doctors have said. I mean, it's a huge advantage.
Mm-hmm.
You know, and then let's say your doctor says, well, gosh, in order to further evaluate this, we need to do a CT scan, okay? Well, if a CT scan has already been done, we will see it in the record and that won't be repeated. Whereas if the record is fragmented, a lot of times testing will be repeated that doesn't need to be, because we don't know that it was done somewhere else.
Right.
So people are really starting to understand the value of that. And, they say, well, gosh, is there an internal medicine doctor? Is there a doctor I can go to with university hospitals here in Conneaut? And I say, well, funny you should ask that. Because actually there are.
Mm-hmm.
And so I think it's really been great for our public.
Sure.
And I've seen a lot of patients go over to their office.
Right.
Because if they get sick, they come here to this hospital, they come to this emergency room,
Mhm.
they come to the doctors on the staff here. And so if all of their medical information is in that one place, it really helps. It's much safer too.
Yeah, yeah. And I remember when you and I first started interviewing, I don't even think that was in place then.
No, it wasn't.
It came into place after we had started.
That's right.
Yeah.
And the really interesting thing, even though we think of ourselves as a critical access hospital and we're only 25 beds, so we think of ourselves as quote unquote a small community hospital,
Mhm.
it's that we are part of that larger net that we call university hospitals.
That's right.
And the ability to refer to specialists, even the most lucrative specialists downtown, all it is a phone call saying, this is my patient, this is their problem, they need to be seen as soon as possible, and just getting them plugged in like that. So it's really easy to network and plug into whatever kind of specialty or whatever the need may be. So yes, it is your hometown hospital where if it's something we can manage, we can keep you close to family and home and take care of it. But if you need highly specialized care, we know exactly how to get you there as well. So
That's
one of
right.
the benefits.
That's right.
Would you be able to take on new clients, new patients?
Absolutely, we still have room.
Because we have a
We're happy to
doctor
take
that's
on.
leaving here, not affiliated with UH, but he'll be leaving here, so you could take those patients if
Yes.
they want to.
Yes, between me and Dr. Kumar, we still have a lot of space to fill
Excellent.
volume. We are happy to do it. Our whole purpose is to serve the community here. We are very lucky to be able to do that, and we want to continue doing that.
Great, great,
And I am going to throw one other little thing in here, given the history that we've had in this town.
right.
I've spoken, I know Dr. Kumar very well, he's a friend of mine, and I've spoken with Dr. Abby too. And, for many, many years before I got here, and since I've been here, we've had what people refer to as a revolving door, okay? Where they will form a relationship with the doctor, like the doctor, things are going well, the doctor leaves.
Right.
That's very disruptive, very traumatic. And having spoken with Dr. Kumar and with Dr. Abby, that's not an issue. they like the town, they like the hospital, they like their practice.
Mm-hmm.
And,
Sure.
You're
You're exactly right. I remember those
oh,
days.
it's been terrible.
It dated back a long time. I remember my mom, who's elderly now, and she went to like 3 or 4 doctors over a short period of time, and she goes, I'm frustrated.
Well, sure.
And luckily, she has one now that's been here a while, and so it's worked out for her.
Yeah.
You know, so I can understand.
Well, another mechanism that we've put into play to avoid that from happening as well, I think one of the problems is every time a doctor leaves, there's a huge hiatus where there's no one filling in, there's no one covering, there's no one who knows the story, and patients have to start from scratch again. And that's why we're so involved with the residency program with university hospitals as a recruitment tool, so that we constantly have a self-sustaining system where if there was a doctor that was going to leave, there's another doctor that's ready to come in and take over that same practice and have those charts and have that information and continue to practice in the same fashion. So we want this to be a true academic situation, even though it is out in the community. We want us to have a residency track where we can continue to do that.
Now, I'm glad you brought that up because that was something we did want to cover. Patients who come to this hospital see residents. The residents see the patients and are very much involved with their care. It's part of their training. I was hoping that Dr. Abbey might be able to tell the public who, okay, I'm being admitted by this doctor, but then these other doctors came in. Okay, kind of explain to people who the residents are, what their responsibilities really are, what their relationship with what we call the attendings are, and how that whole thing works.
Okay. So currently, the residents that we get are actually from main campus, from downtown university hospitals. We are currently in the process of developing our own residency track, so those residencies are just for Ashtabula County. What a resident is they are a full-fledged doctor, so they have their medical degree, but they're supposed to do a certain number of years of training underneath what we call an attending physician. An attending physician is licensed, and so that's for even more safety and security to make sure that those residents are able to practice independently once they're complete. So usually the first person that you come into contact with is one of our residents who gets a good history from you and all of that, and then goes ahead and presents that to our attending. So it's partly a teaching process and a testing process, but they're also delivering care at the same time. This is a very important tool, not just for Conneaut or Ashtabula, but across the nation. It's in every hospital, or in the majority of hospitals across the nation. Without that, we wouldn't have new doctors coming out.
That's right.
So we need that to keep our medicine going, to keep our research going, to keep our patient care going. It's an important tool that we use to train new physicians and make sure that they're ready to enter the world as independent practitioners.
So the residents involved in the care, you know, and they're seeing the patients, they're discussing the patients, and they, you know, a patient in the hospital is a dynamic situation. They come in, they're in a certain state, testing gets done, therapy gets done, their situation changes, you know, maybe something else happens. I mean, you know, it's a situation where there's constant monitoring and constant decision making. When decisions need to be made regarding the direction of the patient's care, what is the relationship between the resident and the attending in terms of making those decisions?
So it's a collaborative decision, we like to think, because at the end of the day, the residents are closer to textbook medicine than we are, because now we're a little bit detached. So we learn from them as much as they learn from us. And that's a very important concept to keep into place. So what we request from our residents is that they get the full history, exactly what the patient's story is. And then they present all the labs and all the vital signs and all the information we need to hear. And then they do present to us what they think their assessment of the situation is and what they think the plan should be. The attending physician is there to correct that or modify that or educate the resident on what else might be added or what might be taken away. So it is a collaborative effort between both parties to decide what to do for the patient. And that's probably the best thing in patient care, having those residents and those people who are so close to textbook medicine available all the time. That's a huge advantage for patient care.
Yes, it certainly is. It certainly is. You know, so much of medicine is experience. You know, I mean, of course, you have the benefit of the current research. Residents who are closer to their academic portion of their career, they're seeing the newest things and so on. But actually putting those into play in real time with real patients, any doctor who does that from the time that they start, they're watching what happens. They're seeing, and they're starting to see patterns among different patients, patterns in disease processes. They're starting to realize, okay, well, the textbook says we can do this, but I know from having done that in this situation many times that there's the possibility of this. That's experience. So the residents are getting the benefit of the attending's experience.
Mm-hmm.
And the attendings are getting the benefit of hearing residents say, well, we just learned this and this might, so it truly is collaborative.
You know, folks, we have Dr. Bryant and I are going to do a show in a few weeks in March, questions that you have asked. One of the questions I have to throw out to both of you, since you're both here, that was asked was, in the old days, a lot of times when women had babies here, they don't do babies here now, but you'd be in the hospital maybe a week. Now it's a very short period of time. And for a lot of different things, even for heart problems and stuff, you're in and out. Is that the insurance thing? That's the person was asking. Is it because of insurance? Is it because of lack of space? What is the reason for short-term, which I think is a good thing, short-term hospital stay?
Well, I certainly have my perspective on it. I'm sure Dr. Abbey does too.
Mm-hmm.
Do you want to start or you want me to?
Sure. So there is actually, and as we were going through medical school, this is something that was really, really stressed. And maybe not a long time ago, it wasn't stressed because it came with statistics and new data and all of that.
Okay.
So keeping a patient in the hospital for longer than necessary opens them up to having infections, falls, and multiple other, you could get blood clots because they're not walking around. So there are multiple what we call like hospital acquired conditions that can happen when you keep them here longer than they need to be. So that was the basis of why that came into play. We found, based on the data, that when you have shorter hospitalization times, you actually have better patient outcomes in most cases.
I never knew that.
Yes, in most cases that's what we found. And then insurance companies started to say, well, since this is in the best interest of the patient, plus it decreases our cost, it's the right thing to do. And then we started putting in guidelines and implementing systems and procedures for that.
So it really is. I mean, I think it's important for people to realize that this isn't simply dollar driven, because it's not. It's science driven.
Mm-hmm.
Okay, and if people, I'll give a real simple example that I think is easy for people to understand. All right. When I started my training, for example, gallbladders were not removed using a laparoscope. That hadn't been invented yet.
Okay.
Okay. We made what was called a right subcostal incision. That's a pretty good size incision below the rib cage on the right side. Elderly people walking around now, they'll know what I'm talking about. They have that incision. All right. That's a big incision. Okay. That is painful post-operatively. That's a big hit to take. Okay. I mean, if you got a bad gallbladder, you got to deal with it.
Right.
But you have this big incision, and it's hard to cough, it's hard to walk around. It takes a while to recover from that, okay? So, of course, they would be in the hospital longer for pain control and to receive other supportive kinds of care to recover from that big operation. Now, the incisions are very small, and the amount of post-operative pain is orders of magnitude less. Okay, when you have your gallbladder out.
Okay.
So if you look at a patient who had a right subcostal and a patient who had the little bitty Band-Aid incisions, okay, the one who had the small incisions is not going to require all of the support that one who had the big incision.
I understand that, yeah.
Okay, so they're not going to need to be in the hospital.
Okay.
In the same way that somebody who has a big abdominal incision.
How many years ago did that change?
That changed in about 1990.
Is that right?
Yeah.
Wow.
Yeah, right around, it was interesting. 3 different surgeons came up with the idea of doing it at the same time in the United States. So it came from 3 different places at once.
I'll be darned.
And where I happened to be in Indianapolis was one of the guys who invented it.
Oh.
And I actually learned how to do it from him.
No
One of the
kidding.
guys who invented it. Yeah.
You know, Doc and I talked, Dr. Abbey, about, we've done this show for going on 9 years, actually, and in that period of time, how much the technology has changed even then, let alone 20, 25 years ago. You know, it's amazing.
Oh, it is, and it's not slowing down. What's coming is really crazy. But
And I've had older relatives that had that gallbladder, and they were in a lot of pain.
oh gosh, yeah, terrible. And the thing of it is, it's not just restricted to gallbladder. I mean, that's across, and
Sure.
in terms of procedures and surgical procedures, that's really across the board.
Mhm.
So much is being done now with what's called minimally invasive, the least possible trauma to the patient, which has resulted in a lot shorter hospital stays, lower complication rates.
Mhm. Mhm.
But Dr. Abbey's absolutely right. The longer you're in the hospital, the higher risk you are for complications.
I never knew that. So thank you for explaining that,
Yeah.
both of you. It's something that apparently somebody wanted to know the answer to, and I didn't know the answer, obviously.
Yeah, well, that's all right. That's what this show is
That's
for.
what you're all about, right?
Dr. Abbey, there is an imperative within university hospitals that's called HRM, High Reliability Medicine. It's sort of an organizing principle in UH these days. And I think the public might find it interesting to know what that is and why UH is placing so much emphasis on it.
Yes. Actually, and this is something that's happened in the last year to 2 years, and as Chief Medical Officer, it's a very important concept to know about, because that's one of our roles, is implementing HRM and making sure it's executed appropriately. So HRM is high reliability medicine. To boil it down, for example, you can go to one doctor with a cough, for example, and they may just say it's viral and not give you anything and say just take over-the-counter medications. You can go to another doctor with that same cough and they may say, oh, you need an antibiotic for this, and give you an antibiotic. You can go to a third doctor and they'll say, you need a chest x-ray, and you might get a chest x-ray done. So what we found going forward is that there's so much variation in medicine that is probably not a good thing. Although we want doctors to keep to inject a little bit of their perspective into things, we do want to standardize most things for most purposes. So high reliability medicine actually took off. It was piloted by some of the conditions that cause the highest mortality, so the highest death. One such example is sepsis. Sepsis is a national phenomenon where, if not treated quickly enough and correctly, it can lead to death very, very quickly.
Now, sepsis means that you have a bacterial infection in the bloodstream.
Yes. So you may come in...
That's what we're talking about.
Mhm.
Right. So it may have been an infection in your foot. It may have been an infection in your lungs. It may have been a urinary tract infection that's now gotten into the blood. And that happens very, very quickly. So what happens is your blood pressure starts to drop. You can, your heart rate can go up. You may need to be intubated, which is, we put a tube down your throat to help you breathe. You may need support, cardiac support, to keep your blood pressure up and your heart going. So that situation needs to be identified and handled very quickly. So sepsis was one of our pilots for high reliability medicine. We found that doctors were dealing with it differently in different institutions, and depending on who the physician is. So we decided to standardize that in our electronic medical records. So everyone who comes in with sepsis due to pneumonia, for example, there's an order set to standardize. These are the antibiotics we use for this. This is what we do with fluids. This is what we do with repeat lab tests, so that every doctor treated that the same way in order to decrease deaths. Our goal was to save 100 lives in the first year.
So the standardization, what went into that standardization, what was chosen to be in that standardization, how was that decided?
So that's completely evidence-based. We practice evidence-based medicine. So these are based on the Infectious Disease Society of America and the CDC, which is the why am I forgetting what C stands for?
Center for
Disease Control recommendations. So it was based off of those guidelines and those recommendations, which are evidence-based. So these are from various studies. Much data was included in this, and it shows that when you handle sepsis from the get-go like this, you improve the patient outcome. So that's where we got that.
Very important for people to understand that, you know, because people sometimes, you know, ideas start running through communities and so on. Oh, well, you know, it's just all a cookie cutter, you know, and I'm not really an individual, and I'm just getting cookie cutter medicine. I hope that what Dr. Abby has just described helps people to understand what's going on here. If you've got very responsible people who are very passionate about their research, okay, and really finding things that work, and then are able to produce evidence that shows that they work, okay, maybe they discover a process through going through all of this research and evaluating all the data and so on. They come up and they say, this process here is going to reliably result in better outcomes. But this hospital over here doesn't know that, okay? Or this practice over here doesn't know that. The question is, why shouldn't that very critical information, why shouldn't that be disseminated and be integrated into a sort of a standardized protocol, say for sepsis, when we know that it's going to do a better job for patients? It's just crazy not to do that. It's just irrational not to do that. So people need to know that's what's driving this.
Another question for both of you. I read recently that somebody did not want to take antibiotics because it had so many side effects. But antibiotics are necessary, are they not?
That is an excellent question. There's so much confusion in the public about that.
Right. Yeah.
I'm gonna ask the chief medical officer to lead off about that.
So antibiotic use is a very controversial, hot topic. When they first came out, we were using them left and right because they were our savior, and you know, this is going to cure everything. Now, as time went by, we found that the more we use, and I think we might have had this discussion on one of our shows, my third year as a resident, my senior grand rounds, a lecture I had to do was on antibiotic resistance. So I learned what was going on and across the nation, across the world actually, from overuse of antibiotics. So as we started overusing these antibiotics because they were available, we found that like every antibiotic is used to treat a certain number of bacteria, right? Because it works against that bacteria. As we use these antibiotics too much, the genetic makeup of that bacteria started to change, where it no longer worked on that bacteria, so it became resistant. So what did we do? We go out there and we try to find another antibiotic that works on it, and another one, and another one. And now, so you've got the rate of antibiotic resistance, and then you have the rate at which we're trying to come up with new antibiotics. And if you look at that graph, the resistance is going up much higher than the rate at which we're able to come up with new antibiotics.
It's scary, folks.
Wow.
Yeah.
Let's make this concrete. Okay, you're out there, you start having fevers, you start having a bad cough, chest starts hurting a little bit, you come in to the hospital, you've got pneumonia. You've got pneumonia. Okay, well, that's something that we treat with antibiotics, because it's usually almost always not always, but usually a bacterial infection. Okay, and so you come in, you start getting antibiotics, and the bug that you have, the antibiotic doesn't work on.
Oh.
Now they're trying to treat you, but the antibiotic doesn't work. Now you are in trouble. You are in trouble. And there are organisms that are popping up that are resistant to everything. Everything, okay? It's very scary. They haven't really gotten out yet, but they've been documented in a few places, some of these super bugs.
Okay.
And if you get a bad infection with a bug that's resistant to every antibiotic that is, you may not survive that.
Really? Is there an
Absolutely.
alternative? I mean,
No.
We haven't found one yet. I mean, there's research going on, but we haven't found one yet.
wow.
There's certainly research going on, but it's And Dr. Abby's right. I mean, it's a race, and so people have to understand that. Well, you know, you're sick, you want an antibiotic. It's a natural enough thing for people to believe that. However, just think about the scenario in which you get a bad infection and the antibiotic doesn't work.
Mm-hmm.
Overusing antibiotics leads to that, and all of us are sensitive to that.
Okay.
So to answer your question, if you really need an antibiotic, then the side effects are irrelevant, because that's not something where you can say, maybe we can treat this, maybe we
Okay.
can't. If you have a solid infection that's going to kill you, it needs to be treated.
Okay.
That's right.
Having said that, you don't want to overuse it if you don't need it. So it can be your best friend or your worst enemy.
Okay.
I think one of the scenarios that docs encounter is a patient who comes in with a cold, upper respiratory infection, and wants an antibiotic. Well, in many cases, those are caused by viruses, and antibiotics don't work on viruses.
Right.
So even though you might think, gosh, you know, I've got this, I need an antibiotic, most likely, oh, yeah, and they will talk to their friends, you know, and their friends say, well, I had this cold, and my doctor gave me an antibiotic, and I got better. Okay, well, the question is, what would have happened if you hadn't got that antibiotic?
You probably would have gotten better.
You would have gotten better.
Anyway.
Anyway, so it's not the antibiotic that did it.
Okay.
See, you just have to understand, it just makes absolutely no sense. An antibiotic doesn't do anything to a virus.
What about the flu? The flu, this is flu season. Have either one of you had a lot of patients with this?
I have.
You have?
I've gotten a lot of patients that had the flu. There is a time frame for which you can get what we call Tamiflu. So usually if you present within the first 24 to 48 hours, within the first 2 days, we can give you what's called Tamiflu, which does not cure the flu. It reduces the severity and the duration of your symptoms.
Okay.
And it doesn't work on everybody. But if you're outside that window, you really just need supportive management, lots and lots of fluids, rest, Tylenol, decongestants.
And one of the challenges that gets thrown to doctors, particularly in Dr. Abby's specialty, not infrequently, is the patient who has the flu and who then develops a secondary bacterial infection in their lungs.
Mm.
The flu compromises their lungs, they're producing all these secretions, they're having all these problems, and then secondarily, because the lung is compromised, a bacteria is able to set up shop. And now you've got a bacterial pneumonia complicating the flu.
Okay.
That's the situation in which antibiotics would be used, and it requires the expertise of doctors like Dr. Abby to sort that out and know that that's going on. And of course, with Dr. Mata on staff here now, that is really going to help us disentangle those things, because he can do a special test to get cultures from the lungs and tell us exactly what's going on.
Ever since I've been doing these interviews with doctors for the last 8 or 9 years, I've been reading up on a lot of different stuff. And there's an article today in the newspaper, I think the Plain Dealer, or the Star Beacon, I can't remember which now, but it was talking about vitamin D. And I think you and I have talked about vitamin D. It's very important for us. And it said there could be side effects from that also, but mostly it was for the good. It wasn't bad thing. So can you explain what that does, vitamin D?
So vitamin D has been this hot vitamin for a couple years now. Vitamin D predominantly comes from the sun, not as much from your diet as it does from the sun. And because we live in Northeast Ohio and we have such low sun exposure, many people are vitamin D deficient. I'm vitamin D deficient, for example. It's been associated with many things. Well, one of the most important associations is with good bone health, so strong bones, and things like that. When taken with calcium, it's good at preventing osteoporosis from developing, which is thinning of the bones. But also it's been associated with very low vitamin D levels have been associated with fatigue, like some level of haziness, having difficulty sleeping, so pretty much increased frequency of falls in the elderly. So it has a little bit of an association with pretty much everything.
Okay.
So we got into the habit of kind of testing vitamin D levels on everyone. And you can take it over the counter, but you can also have it prescribed if you're very low.
Is D and D3 two different things? D3?
We usually give it in the D3 form.
Okay.
That's just a form. Vitamin D gets metabolized in different places in the body. And the molecule, the vitamin molecule gets altered slightly, in which case you call it D2 or D3, that sort of
I
thing.
take D3.
But D3 is standard.
That's
That's standard
okay.
oral
Okay.
therapy.
So that's okay?
Yes.
Okay, okay. Sorry with all these questions. I
Well,
just-
no,
That's
that,
okay.
that's,
That's what we're here for.
that's what the show's for. Yeah, I mean, vitamin D deficiency has even been implicated as a risk factor in some malignancies. So colon cancer is one of them, prostate cancer
That
is
was in the
another.
article today.
Yeah, so it's not good to be vitamin D deficient. Like anything, vitamin D is a fat-soluble vitamin, and you can get too much. But how many cases of vitamin D toxicity have you ever seen?
Yeah,
I mean, I've never
not
seen
very
it.
many.
It's very, if you take the standard dose, a couple thousand units of D3 a day, you're not gonna
hurt yourself.
No,
Okay,
no.
okay,
That's basically all win and no lose if you do that.
okay, cool.
All right. Well, so I hope people are getting from this. Dr. Abby serves a very important purpose at UH Conneaut. She's really the liaison between our medical staff and our hospital and the greater UH system. And she works with her colleagues downtown and in other UH hospitals to bring the thinking and the programs and the initiatives from the whole system out to our hospital. She's also very instrumental in developing the residency program out here, which is going to be huge for us because that will alleviate the difficulties that we have had in maintaining a stable primary care community in this town. So we really want to thank you for taking time from your very busy schedule to come and explain all this stuff to us today.
Absolutely.
Okay.
Pleasure to be here.
Thank you
Thank
for coming
you.
in. Great
Yes.
seeing you again.
Great seeing you.
In a while. All right, folks, that's our edition of Your Health Matters. We'll see you again next week.